afterwards. So, okay. Well, here we are. It's been, I think it's been about a month since we last met, and there's been a lot of activity, action going on. And so I'm glad that we have a chance to get back together again today. So what we want to do, what we talked about doing here is just doing some quick updates. Actually take about 20 minutes or so to go through these 4 topics, some recent presentations about the work we've been doing. Ken Lord and I think Ken Salyard I saw as well as on are going to talk to us a little bit about the applying FHIR to surface services and surface determinants. And Brian will give a quick update on some of the many standards bodies that he and Eric and others are sitting in on. And then just a second on what's happening in California. And I hope to spend at least half the time, maybe a little bit more on the consent learning lab report that we are cobbling together now from HIMSS. At the same time we're doing that, we're also putting together a report for California on many of the similar topics, but specific to California. So, I've just got some initial stuff to share with you that we reported out last time on, and want to have a conversation around how do we prioritize that set of recommendations down to, a few fabulous things that we can plan to do over the next couple of years. So sort of crowdsource the recommendations piece of this. So with that, is there anybody new to the call? I think there are a couple of people who I hadn't seen in a while, maybe. Anybody new to the call? If you are, I'd love you to say hello, introduce yourself. Anybody fall into that category? Nicola, I'm wondering if, I know you've been on before, I think it's been a while, right? I can't hear you if you're talking. Still can't hear you. That double mute, maybe. All right, well, welcome. Glad to see you here. So let me jump into just a couple of things. So a couple of weeks ago, I had the good fortune of being able to present with some colleagues at the 201 San Diego annual conference on consent, and Bill York, who is the CEO over there, set up a plenary to talk about consent. So the Dr. Lynette Scott was on the call, myself, find help. Go ahead, help me remember who else was on the call. And Camden Coalition was on the call. We had a chance to talk about sort of just in time what was happening. It was a good call, and keeping the momentum going in California around consent, especially with the projects that got going around kind of a universal consent. So I think that video will be available for folks. I'm not sure when it'll be available, but I'm pretty sure Bill said it was going to be available. But it was really good to see more momentum around that. The following week, I had a chance to present at Civitas. They have like a monthly call, I think, for the HIEs. And Robbie Franceschi from Blue Path Health, who we're partnering with in California, and I spoke about the work we're doing in California and more generally about consent and the utility to, I guess there were about 100 people on the call from many of the HIEs, and there was a very engaged conversation around it, and recognizing and the recognition of the need for utility within the HIE world, especially within the context of their data utility concept that they're promoting. So that was great. I think also they make those things available as well. But the headline on that is, we're spreading the work broadly around the country with organizations and people that are interested in consent. And the good news is that we're able to share that. The bad news is that there's just continuing. It just reinforces how important it is that this work is consolidated in some fashion. because we can stop recreating the wheel. And now we have a good distribution channel for it. Christine, do you were in St. Thomas recently? I know you were participating in a conference that I thought was interesting. You want to say a word about what was happening there?
I can say a word, and I hope to have more words to say maybe next time around. Just given that my husband was having a medical emergency while I was there.
Okay.
But so the only thing that I was paying enough attention to share right now, well, I guess there's two things. One is that Dr. Sandra Ford, who Daniel and I had met with multiple times back when she was running the White House task force on social determinants of health, which is probably not quite the right name for it, but was the keynote speaker at the meeting, and it was able to, present a really nice presentation on the work that she and many colleagues did to try to put together an action plan for the federal government that really will be great if it ever gets released. So that's the punchline, is that, it's caught up in some level of red tape and it's not released. But if it does get released, it really will provide, I think, exactly the kind of direction that we're all looking for from the feds, to have them recognize the need for much more cross-sector collaboration and initiatives, both on the funding and on the data side. Data standards very much were part of the action plan, as well as braiding and blending of funding. And so, hopefully this is something that's going to get, unstuck and move forward and come out to benefit all of us. The other thing I just want to say, and I hope to be able to report on it in more detail after I get a chance to review the talks that I didn't get to listen to, is that there was really good participation in the meeting, both by ONC as well as by Sequoia and others. And I heard snippets of their conversations, and, again, really, I think starting to be much more forward thinking and looking beyond medical care in the goals that they were laying out and what they were saying. So I will get a chance to review those talks and come back and just be able to share a little bit more about what was said by the feds. And, I think it's always interesting when you talk to a very tiny place like the US Virgin Islands, which has less than 100,000 people. And yet it just has, the government has a lot of power in a way. So, and they're also very well funded at the moment. That there's an opportunity potentially to try to do things there, and to use that as a proving ground for some innovative work. Already they are very much in the midst of building an integrated eligibility system using Medicaid 90/10 funds. So that's, one of the kinds of innovative things that they're doing that starts with Medicaid, but crosses over into programs from USDA, et cetera. So more on that once I can speak a little more definitively.
Thanks, Christine. It'll be interesting if, if things get released around the new budget year. So, getting through whatever review process, because it sounded like that was kind of the target was the fall. I don't know. I was talking with a fellow who stepped in behind her, who's a White House fellow. I forgot his name right now. But that was the kind of the timeline he had mentioned. But so that would be great, because, so much of our recommendations are sort of embedded in there, or at least they're consistent with what they're saying there. So
right. So as the next fiscal year's funding is released, if it comes with both an emphasis on braiding and blending and on the IT work that needs to get done, you're right.
Yeah.
That would be great.
That'd be really cool. Well, great. So we'll put it on the topic, one of the agenda topics coming up. Fill up that agenda. So with that, that's a good segue over to Ken and Ken. around what's happening with at the federal level and with fire and social services. So Ken, do you want to do you have slides, or do you want to just talk?
Thanks, Daniel. First of all, I'd like to maybe talk to Eric, because Eric sort of put something on this, and is this what we want to talk about? Because there are multiple dimensions that we could talk to stuff. So Eric, you've seen multiple presentations over the last couple of days that are somewhat orthogonal, and I could talk to this topic, which
yeah, and what's really I don't know if this is exactly the I mean, that's kind of ambiguous what we've got on the title right now, but but I think what's of key interest to this group is silo busting, and your work with the Administration for Children and Families as a consultant with MDIX Inc. To look at adding the concept of a person that is not a patient of in a clinical setting to fire. So I guess that's what it's alluding to, this statement. But I think that's of key interest to this group to present on that topic. Sorry.
So let me talk at a very high level and try to capture both of those. And in addition to that, sort of the visionary and sort of executive sponsor to this is Ken Salyards, and Ken knows nothing about that I was going to talk today. So and also working with Eric and Brian and Christine, this was sort of a last minute thing and didn't get the chance to do that. So let me sort of ramble for a few minutes. Sure. And then sort of try to paint a little bit of the landscape of what we're trying to do, and hopefully Ken will be pleased, but we shall see. So with that, there are really two things, and I think all of you know about ODH, and I'm just going to make that assumption. Yeah. So around ODH, and ODH has been implemented and is being implemented in various places. And one of the things sort of, and ACF is really the driver in a lot of that. And during that process of doing that, they have found that in their implementation, there are certain sort of concepts that are difficult to implement within fire. And specifically, those revolve around the subject being a person, and then what type of relationships we can have of that person to various other types of concepts, whether they're goals or conditions or observations, findings, or even service requests. So that in and of itself makes it problematic, and I'll explain a little bit more about that, why. But in addition to that, as more important, the whole concept of what social organizations in an abstract view, and how we can get our hands in the importance of social organizations and members of social organizations and different types of social organizations, whether they're households or families. Or
part of any type of vocabulary service as well, because
I'm sorry, I didn't quite hear the question. Apologies.
I think it was just somebody talking over you.
Well, that's okay.
If people have questions, please put them in the chat.
Okay, and I'm not looking at the chat, Daniel.
Yeah, okay. I'll keep my
interrupt whenever it's appropriate.
Yeah, great.
Okay, but as important as sort of the concept of a person being a subject of various activities and observations and judgments, the idea of how they deal in their particular social environment and the groups that they form, like households and families, are important to the work that is being done in ODH, but it also is important, I think, to a lot of people in this room. And so one of the projects that that we're doing within the HL7 Health and Human Services work group is a project, is enhancing fire to address social services and social determinants. And that is driven by the problems and the sort of the lack of liquidity of data and fluidity of data between various organizations that are trying to provide services for an individual. And as part of that project, and I'll sort of go back to what Christine was talking about. So it's going to be use case driven. There are use cases there. We have a Confluent site, et cetera, and I'll try to provide that information later. But in the use case driven, we have use cases up there, and the use case itself defines 3 different layers of information and driven by subject matter experts. One is a description of the use case, which is, just textual description. The other one is information around the personas and actors in that, to the point of we will be able to develop demographic data and also other types of data associated with that individual. And the third part of the use case is requirements, and it's really logical models, because the key issue is that what we're trying to do, and the problem set is that there are organizations out there that have a very clinical focus, perhaps a behavioral focus, and delivering services associated with that. But there are also services out there that are social services and that are very important to achieving better outcomes. And as a care manager or a case manager, one wants to achieve and obtain the appropriate services in as timely and as efficient manner as possible. And it's not, paper, phone, and fax is not necessarily the most timely and efficient manner. So a lot of it would have to do with electronic information exchange between these two parties. And so some of the work that we've talked about within this, and I'm going to pick on Eric for an example, is there are some very massive sort of, both from an intellectual capital perspective, but also from a system perspective, dealing with housing insecurity. And within those housing insecurity capabilities, they're very oriented on providing services for a person. Whereas within fire, the ability, it's focused and limited in scope a little bit to providing services to a person who's in the role of a patient. And there's an impedance mismatch with there can be some ambiguity associated with that. There can even be some privacy rules. So what we're trying to do in this enhancing fire, and Christine probably just talked about one that she saw in the Virgin Islands, and that around an eligibility, a logical eligibility model for social services for ODH, which is fire centric and built on fire, and participating with other organizations who provide services for the individual and don't have the concept of a patient. And so we're trying to develop logical, the task right now, and where I think our effort is right now, is developing sort of very simple logical models for a particular type of social service eligibility, and then from that point, trying to then, not only model, but do some very simple prototypes associated with that to show sort of the as-if fire model and how one would have to deal with that, as well as the HUD model. We would do that, but also we would take the as-is model and that exists in Fire 5 and start making some enhancements associated with that. So we'd like to see and it's and prove that there might be better ways that we could enhance fire to enable the community to deliver and to identify and deliver and track social services within sort of a care management, case management process. So that's sort of the, the title of what that was. And then sort of Eric, just in terms of doing that, sort of we built, and this again is sort of within ACF, we've built the capability, and it's nascent, and I have to admit that, but the capability that how we really want to do this is through semantic semantic binding between data models, so that we have a clear, concise, accurate description of really what things mean in these various different domains. And so that's sort of another part of what's some of the foundation of this, but from what we're trying to do that adds value out into the community directly. And all of this is in open source, and what we're doing, open standards, open source. But the value we hope to deliver into the community is to provide recommendations on how FHIR and what we're doing within FHIR and all the capabilities it has to interoperate and exchange information with other organizations who are delivering social services. So high level, that's what we're trying to do. I sort of covered two things, Eric. So Ken, we actually have a meeting later, so you can make all your comments to me then. But Eric, is there anything, because you've been involved in some of our work, I know Brian has been too, but Eric, you've been involved in some of the work, especially the semantic foundation work of what we've been doing over the past several months. So I'll give you that opportunity. Yeah.
Oh, no, I just, no, excellent, Ken. I don't have anything to add. I think we just wanted to have a quick introduction to the work that you're doing and its relevance to social services, and how it can be extended into other areas such as social determinants of health and other areas of FHIR. No, I was just hoping we could open it up to Q&A real quickly, and then we had 15 minutes allotted for this topic, so it's probably.
Sorry, I probably talked too long. I apologize.
No, it's excellent, Ken. Thank you so much. And does anybody have any questions about what Ken has presented?
So I have a question. I have a request. So I always, you always have an ask in one of these things. And our ask is that if there are subject matter experts in this organization where you have where that problem or condition resonates with what I've said, we're looking. We don't want to drive this as a technology. We want to drive this as added value, and how we want to do that as use cases. So those who have knowledge of use cases, especially around eligibility, but other use cases, I know Brian has talked about referrals, and which is a little bit further down the pike on that, but happy to, we'd really like to engage in the community, make sure what we're doing is the right thing and is it value.
The personas that you've defined to date, the hypothetical users you've defined, are they based on Shift or PP2I personas? Were they created from scratch? So I know they're not Gravity or Unify personas.
Well, so we took and sort of created a hybrid situation. We definitely followed the Gravity template in some ways. We've gone based on the requests of the HL7 group, driven a little bit further into the requirements section. So we're using the templates associated with that, and some of the high level, we're trying to keep some of the personas associated with that and leverage them. But the use case work really, and I'm not a subject matter expert, as I'm sure is pretty obvious here, but the use case of that has been driven by Michelle Zakan, who's a co-chair and someone who she works for. And I think Christine has had a chance to review some of it just for relevancy. So that's not a specific answer. to your question, Brian, but we are trying to leverage what's being done in HL7 and Gravity to make sure that the methodology that we're using is applicable and can be reused.
Okay,
Yeah,
great.
and I can add a little bit more detail in that, some of the personas came from work that was done it was adapted from work that was done for the maternal opioid misuse and Inc. projects, but we specifically wrote them taking the medical needs of the person out, so that these personas are literally almost lacking in medical issues in order to make the point that that this type of intersectoral care coordination is necessary regardless of whether they have medical issues or not. And then, as Ken said, again, trying to use the sort of the guidelines and to create the sort of structured data that is very similar to what's being used by Gravity, just extracting out the medical piece to just really drive the point home.
And if I recall correctly, Christine, we also started with the project, well, the Inc. Use cases had their genesis with the project Unify, Jameson and that whole cohort.
Right.
So
but
it did have a Unify basis. It's just we had to modify it, as Christine said.
Right. And there was a whole other set that Michelle Zancan had also created of a pregnant teenager for the maternal opioid misuse project out of CMMI as well. So that was the other sort of heart of some of these personas.
So that's great to hear, and thanks, Ken, for sharing that. I think that's consistent with what the other Ken has said to us in the past.
Oh, that's good. That's a good thing. Ken, do you have anything that you'd like to add, or you're all set?
Yeah, I think we're all set. It'll be good once we get these changes into FHIR so that we can actually build some code around it.
Cool. Well, it's actually very appropriate for the conversations we're going to have, not only for the next hour or so, or whatever, 45 minutes, but also over the next couple of weeks, which is I'm really focusing in on those use cases, focusing on those proof of concept sites that are actually doing that, literally bumping into that right now across the country. So there's 3 or 4 sites, including California, Minnesota, New York is doing it, Washington's doing it, amongst others that are interested in this. And so there's actual places that want to do this, that are doing the work now. And so we got to come back to the need for aligning federal, state, county, local, CBO. It's got to be, we got to have a vertical stack in order to really drive this in a place like California or Virginia or Pennsylvania, New York, where you have such important county entities that are delivering through the CBOs and stuff, as well as in state entities as well. And so the thing that is really important, and I really hope that we can build on this and really have this, take this conversation to another couple of levels, is the work we did at HIMSS, right, was 60 subject matter experts from across the country. Everybody in that room has a proverbial dog in the fight, I might say. So, and many of those people contributed to the prior work on the scan that is now being updated specifically for California, and trying to distill out of the work from Chicago and HIMSS, sort of what are the really the key things that we need to focus on now? Because we recognize this is a 10-year effort. And we started this effort 10 years ago. Some people started more than 10 years ago. But consent will be a long-term initiative, and that if we can help align now, both from a funding perspective and from, as we'll see in the recommendations, just tell us what the right answer is, right? Or get out of our way, so to speak, and let us go wire it up, give us the codes. To have that agreement between the federal and the state and the counties is so important. And, I know that folks on the call are, experience that every day. So I would implore us to really think about connecting those dots. And as Christine reported earlier, if the White House comes out with that and it gives that kind of direction, that's what we hear continually when we talk to people across the country, is just define for us what is within the bounds, right, and what you want us to use, and that's really good. So with that, let me turn it over to Brian for an update on some of the technical underpinnings of this work. And I'll open up the slide again, Brian, if you want me to do the annotated one or just the top level one.
Why don't you do the top level one? If anybody wants an eye chart, they can look at the slide after this one, which is all of my notes that I'm going to read from. But it's very hard to read on a slide format. So I'm going to rattle through this fairly quickly so that Daniel has time for other things coming up. Just for everybody's FYI, we have a CMS virtual connect-a-thon coming up on July 18th, 19th, and 20th, where I expect we will see folks testing out FAST, the Fire at Scale Task Force work on security and directory services, et cetera, the National Directory, Gravity, Passio, and others, I'm sure will pop up for that. Then moving on to Gravity Project. Within Gravity, we've restarted the community working group, the collaborative community working group, I think it's now called, which is working on defining codes for digital access and digital literacy. And the most recent meeting, we were talking about also the need to consider adaptive equipment for differently abled individuals. A lot of the discussion happened around the question of, well, is it sufficient to have for instance, a library that has computers that have internet access? I think part of the concern that was raised was, well, in general, yeah, that provides low-income people broadband access, but do you really want to be sitting around a library talking about your healthcare with a doctor and a telehealth visit? Probably not. So maybe the existence of a library with public internet connections isn't necessarily meeting the needs for digital access for healthcare or social care. The next meeting for the Gravity Project will be Thursday, July 6th from 4 to 5:30 p.m. There's also a technical working group within Gravity, which has been defining the SDOH clinical care IG, the closed loop referral specification. That working group has spent the last month or so prepping for the CMS Connect-a-thon. Their next meeting will be on Wednesday, July 5th next week from 1 to 2 p.m. We're still planning on publishing STU2 for that SDOH clinical care IG. And they've also identified a new eligibility use case based on CDS hooks for asking, for instance, Medicare Advantage plans if somebody is eligible for a particular home and community-based service that somebody wants to refer them to. That's being considered for inclusion in a Passio Connect-a-thon, either for the CMS Connect-a-thon in July or the HL7 Connect-a-thon in September. To make things really interesting, there is an HL7 Orders and Observations working group. It is HL7 International. The Gravity Project is US realm focused at the moment. Orders and Observations have been dealing with the same challenges of how do we make use of fire service requests and fire task, for instance, for putting in laboratory order requests. And the need for being able to do kind of an international-based closed-loop referral for healthcare services in general. So they have added into their remit the idea of being able to do social care referrals as well as laboratory referrals and specialist referrals, et cetera. So they're now tackling this problem at a global level. How do we define closed loop referrals for all of these different kinds of things? And fear not, as soon as I saw that that was happening, I sicked Bob Dieterle on them. And so we have some alignment now between the work that Orders and Observations was doing and what the Gravity Project has been doing. So that also opens up an opportunity for further tweaking on what is being focused on in Gravity. So we shall see. Their next meeting is this coming Friday, Friday, June 30th, 10 to 11 a.m. There's an HL7 community-based care and privacy working group that has recently been working on fire data segmentation for privacy. How do we do fine-grained marking for privacy requirements for individual data elements within a record? They also are the home organization, or one of the home organizations for PASIO, which had previously been working on acute care transitions supported by ELTSS, Electronic Long-Term Support Services and Care Plan. They're right now working on advanced directives and personal functioning and engagement surveys. They are very interested in what is being proposed for ELTSS for SDOH. And since that is something that was done originally as part of PASIO and now is being refunded by the ONC, both by providing funding to EMI advisors to do a crosswalk mapping between Gravity's SDOH requirements and the long-term support services IG that have been created for acute care transitions, to extend that ELTSS specification to support transitions from home to skilled nursing facilities, to be able to capture what has been going on in terms of social care services as well as healthcare services for that individual at home, so that we can ensure that when they go into a nursing home, that they have what they need, as well as to be able to handle the transitions from skilled nurse post-surgical nursing, skilled nursing facility back to home, and making sure that all of the support is going to be there for them to return home. So this is a fun and exciting new project that's also being funded by HL7 to provide a contractor. LMU is going to be doing that, to take the original STU1 ELTSS, dust it off, bring it up to date with the latest specification technology HL7 is using, and then expand it to support the requirements of Gravity's SDOH, as well as what has been learned from the Missouri ELTSS-based social care referrals project. Next, HL7, I'm almost done. HL7's Human and Social Services Working Group has been working on a Human Services Directory IG. It went out to ballot a while ago. We are nearly done with ballot reconciliation on that. I'm expecting we'll probably have an ST, unless the wheels come off the trolley between now and then. I'm expecting that sometime this fall we'll end up with an ST1 publication of that Human Services Directory. That, by the way, has been funded by, I believe, ACF. In addition, that was funded by ACL. I've got my notes reversed here. In addition, as Ken Lord just mentioned, we are working on a project proposal for enhancing fire for social services and social determinants. That's being ACF funded by ACF. And somebody correct me if I got that wrong. We're having a lot of fun on the Human and Social Services Working Group. Bring your popcorn. Their next meeting is going to be Thursday, July 6th from 3 to 4 p.m. And penultimately, ICFIS, the Information Exchange for Human Services consensus body, has been working on a number of things. The resource discovery subgroup for ICFIS provided a lot of feedback back into the HL7 HSS Human Services Directory work. And now that that is going through ballot reconciliation and publication, that working group is on hiatus, but we are starting up a new working group, the social care subgroup, to be led by Courtney and hopefully Dr. Mike Klinkman, to start addressing some of the broader social care issues that keep popping up, so that we can help to document that and let folks and provide input to other organizations. And finally, just from a Unify perspective, I wanted to let everybody know that I've updated what we were calling the user stories catalog. It's now called the user narratives catalog. Two basic changes. One, I've changed the wording from user stories to narratives to stop confusing those folks that are of an agile bent mindset. Since an agile definition for user story is slightly different than the terminology we have been using. And finally, I also have removed all specific references to states or towns and cities, and rather described the kind of locales that people were in as rural communities or large cities, in order to make those user stories more usable by projects in various locales. We already know they've been used or looked at in New Jersey, in New York, in Connecticut, in Minnesota, and Chicago, by the way, Illinois. So I'm imagining that there will be broader use of these user stories to help drive people's thinking about what are the challenges that we need to solve in this interoperability between healthcare and whatnot. I'm done.
Wow.
Oh, and my apologies, Eric. I'm sorry, I blew right by you. I was going to turn over part of this to you. Do you want to say anything?
Who's the who?
Eric.
Apparently not.
Eric John, okay. Well, my apologies. I was so focused on trying to get through this quickly for you that I forgot that I was going to turn over, I think I was going to turn over the discussion of the enhancing fire for social services and social determinants. So it's probably moot since Ken Lord was here to give a broader description of it.
No, that's great. Two quick questions, Brian, before we move on. One is, well, three. One is amazing. You're actually got a grasp on all of these different moving parts and pieces. How many are there other people that are crosswalking this in the same way or a similar way in terms of the different standards work across the different standards organizations? Or is that a unique role or task at this point?
Well, I see Courtney in an awful lot of places.
Yeah, okay, yes.
And I see Christine in a lot of these places, and Eric. Not everybody goes to every single meeting.
Right.
Rita has her hand up. She might know better.
Rita, tell us.
Well, I also do pop in a few of them, but I wanted to just make mention specifically to the CMS Connect-a-thon, which I know at least you, Brian, are going to be, I think, participating in, that there have been track prep calls going on, and I'm specifically involved with FAST for as part of the work I do with Aegis, and there is a implementer prep call for the FAST infrastructure track tomorrow, just as an FYI. So thanks.
Great.
Back to you, Daniel.
Yeah, no, that's great. I'm just, just on two levels, it sort of reinforces the point that the cross-cutting knitting between these things is really important. And that somehow that's got to be, that's got to become somebody's job, as we like to say, right? One of our key takeaways is this this consent across domains is nobody's full-time responsibility. So
I wish I was funded to go to all of the standards.
yeah, no, that's exactly what I'm saying, is that it shouldn't be. I mean, you put in a lot of time, and it really is. It's really one of the friction points or one of the bottlenecks, I think, in a lot of this work is is doing that sort of cross sector. The other quick question, and probably a longer conversation, is in all of these conversations, are we talking only about structured data? Where has unstructured and narrative data come into play, if at all?
Not very much in the work that I've been involved in. There
Yeah.
are mechanisms within the various standards for capturing unstructured data. And there are folks that actually do worry about how do we convert this unstructured data into structured data.
Right.
But
So,
it's not the focal point of most of these organizations that are on the screen right now.
so Brian, what about like the care plan, like the ELTSS care plan work? Because isn't that a place where you have structure, but within the structure, you have unstructured data, right? So, and you know, that work that particularly was, you know, only done at a demonstration level under the LEAP funding last year by the folks in Missouri, you know, the point was to be able to, you know, put some sort of pretty broad concepts out there about what people need from a number of different areas in order to thrive.
That is one of the challenges that they had, given that the fire care plan resource is really heavily structured data oriented. And
Right.
that was one of the problems that they saw in Missouri, in the absence of there being all of the necessary codes and concepts defined for social care. How do you capture that information? Matt has his hand up. Matt?
Yeah, so most of the fire resources will have some kind of place for a description or narrative, but they will also require a code, you know, procedure code, condition, problem, diagnosis code, etc. And as an implementer, kind of working with social care organizations, that's a big part of an adjustment, right? In terms of if social care organizations that are not, you know, used to billing, leveraging those codes, they oftentimes are not used to kind of searching through and selecting the code, you know, and knowing the fine-grained nuances of, you know, this type of food insecurity versus that. So that is a challenge. And so the more, and also kind of knowing from an implementer's perspective, if you are going to have like a drop down of, you know, procedure codes or whatever it might be, how do you make it as easy as possible so that like they can select from like a hierarchy of, you know, codes, so you're not showing them a massive list of things that are not relevant to them. So this is a very kind of challenging issue in terms of how developing the standards that kind of brings the benefits of being able to bring kind of, you know, the population health or population analytics that a code structured data allows for, while also accommodating the needs of social care. So it's a challenge.
Okay.
Well, and I'd like to jump in here, Daniel, a couple of different things. I think speaking to, I think where Brian may be going and responding to Ruth's notation here about discussion of curation of similar codes and social services ontologies. I mean, one of the things that we're seeing and I've proposed that we're raising in the direct trust venue is really kind of a guide to taxonomies and data sets so that people can understand the differences in social care between INR taxonomies versus data reporting sets versus codes and billing codes, because it is different on the social care side. So I think that's one of the things that we want to look at and hopefully provide some guidance and help out to the rest of the universe on, because I repeatedly hear people telling me that they use LA211 as their data set, data reporting, and that's an INR taxonomy, not a data reporting taxonomy. So I think that there is some work we can do that would be helpful. I think the other thing in this notion of data sets versus really the case notes and things that have to be captured, Daniel, on our side of the world with social care, being able to have that flexibility to gain greater insight and granular knowledge on a client or a patient, because oftentimes on social care, you are grabbing information that doesn't neatly fit into some of those data sets. So having the capacity to do some of that crosswalking, whether AI can help or whether there is flexible opportunities to capture that data so that people can reference it. It
Right.
can just give a broader understanding of the client. And the last thing I'll note is you raised, and I think it's an important topic to raise, is what is the crosswalk that's going on between all of the groups that are doing amazing work, and how is that work aligning? Where doesn't it align? Where should it align? And I think there are some of us that are sitting at the same tables. There are many of people sitting at other tables. But that's something I know I've personally become more concerned about, so that we're not all creating 15 different new wheels, that where really, if we all work together, we could produce one smarter, better product overall. So how can we potentially align some of this work going
Yeah,
forward?
and Daniel, this is Ruth. I apologize. Schedule's been busy. I haven't been on a call for a while. But in this space, my first job moving from academia into the EHR was as a clinical terminologist, curating codes that represent a semantically similar meaning. And those are broadly, that's used in registries, which are, I know it may not have the presence in social care, but it certainly is. I think it's one of the most direct routes towards the truth. And I chair a determinants of health work group through the Nursing Knowledge Big Data Science. I don't care that it's nursing. To me, it's like it's person-centered. But we've actually taken the PCORI social interventions report and pulled all of the studies to try, and because the systematic lit review that was done just mentions this is the domain that was addressed. It doesn't describe what interventions within the study were effective in improving outcomes. So we're actually pulling the data, the information, the description out of the study, putting it into an Excel spreadsheet, deconstructing the intervention, and then trying to look at the NLM VSAC for determinants of health, particularly looking at the interventions, because, when you think about it kind of goes to Courtney's point, man, there's a lot of codes in there, and there's a lot. Some of them are care delivery or service delivery. Others are programmatic specific. So coming up with a way to leverage those eligibility criteria that might be stored either in a social care system or in a healthcare system, using that to pull up, here's a possible scenario for interventions that might be attempted. And again, this could be used on the social services side or on the healthcare side. But for me, as a secondary user of data, I want and will only work with data that has been linked to a standardized code, so it represents a standard meaning, because otherwise the natural language processing, there are not enough resources right now. AI, I don't think is going to take us to the degree of certainty that we might want when you're really trying to decide which series of interventions provides the best impact for this subgroup of a population. So, I mean, that's just a little bit of thinking, because, you know, I'm all about how do we make this easy for the end user to use that can be built in a technological environment, because I want the data. At the end of the day, I want the data so I can tell what worked, what didn't work, so we can move towards best practice in a shorter time interval.
Ruth, and one of the things we see on our end in terms of standardized interventions and certainly the data that flows from that, at least in our network. And so that, you know, the AAAs were mandated by Congress 50 years ago as part of the Older Americans Act and have been providing services on the ground with the help of a massive network, you know, 840 AAAs or Title VIs and 20,000 local aging service providers. That data can differ state by state. You know, states use different taxonomies, they use different data definitions. So very quickly it can become gray and murky, as well as their interventions can vary. And their interventions may be dictated based off of the funding requirements and who the payer is and what requirements they've put into place. So, you know, it becomes hard to produce standardized data and reliable data because it might not all look exactly the same, even though it's similar. And those are some of the things we're grappling with. Yeah. Unfortunately, the data under Older Americans Act does not align with gravity, and it is not easy to crosswalk and convert over because, again, their work is mandated by an act of Congress, and they gave certain powers to the states related to data platforms and all of that.
Yeah.
So and how do we make those leaps?
Yeah, it's the same thing, Courtney. To pry people away from their text-based description of what they did is difficult, but you can use the standard codes as a grouper. So doing, you know, like that quick keyword search. I mean, I've done an analysis on a care management project, and it was very, just in a simple Excel spreadsheet, you could actually derive which grouping what they did and how it linked back to a standard code. It can be done, not easy, but I hear you. The same things are happening in healthcare as with social care. Some of the dogs are just bigger, that's all, in healthcare. Sorry about that, Daniel. Didn't mean to hijack it.
No, it's absolutely perfect. And as you'll see by Christine's comment, it's spot on. You know, this is, I'm so interested in this conversation because it really does help focus our work, right? In terms of what we do next, what this collaboration with this network is able to do in the places we're doing it, and the people have been brought together. And I'm pretty convinced that you know, there's a convergence that is happening, and that a lot of the people in these calls and these conversations are at the nexus of that convergence. And so, you know, I think that there's a real valuable service that we can provide the nation by really sort of getting right what the next couple of steps are. You know, where are the resources focused? At least be able to have our say in that. So your participation is absolutely more than welcome. It's required now from going forward. So we'll track you down for the remainder of the calls here. So thank you for bringing that to the table. And somebody made a comment about the work being done. I said, is this a job for a HEMA? And somebody said, added AMA and AHA are working together. So Teresa, is that actually happening? Is there actual work groups that are doing that kind of code work across those organizations?
Yes, in fact, I know I've been in contact with some of them and actually introducing them and cross-pollinating between the groups that are working on, you know, whether it's Gravity or S codes or, you know, 211 LA in the field, and the individuals that are working on, say, ICD, you know, 10 CM, as well as, you know, kind of within both the medical association and the hospital association. So yes, they're talking in the background to let you know on a regular basis. And the good news is, I think we're going to see more of that cross-pollination happening here in the next few months.
Great. Brian, you got some more room on your standards bodies calendar?
Let's see if we can get me some funding for some of the stuff I'm doing.
Right. We'll pass the hat at the end of the call. So no, exactly. That's the whole point. You know, there's stuff happening all over the place, and it just needs to be. I'm glad to hear the stitching is occurring. So let me, because we're already at 5:15, so we're going to adjust the plan here. So let me just make a suggestion here. So this is the slide that Brian used as detail, which will include. We'll post this onto the Nick site again, and we'll post the recording there. And you'll. We're not. Well, I guess I could send out a note, but it's available for folks who want to get to it. But with that, I want to move maybe in the next 10 minutes or so and just kind of tee this up. I think what we can do is we'll schedule the next call to really dive into this a bit more, and that'll actually give us a little more time to sort of chew on the material, if that makes sense to folks, because we still have some stalwarts on the call, but I want to make sure we expand this. But what I'd like to do is just kind of give it a little overview of where we're at right now, and propose that again this becomes a collaborative effort, almost a crowdsourcing of what we're distilling from that meeting, which is also coming from prior work, that we've been doing on this consent work. So it's kind of continuing to accumulate. And so I put together some slides, and what I can do is I can send them out to folks, and maybe we can read them. And I think that hopefully by next week we'll have a draft of the sort of an overview of the report, which I'll talk about in just a second. That will provide the context and distillation of some of the thinking, and then sort of the synthesis of some of the ideas that I think got squeezed out. We didn't have sufficient time to take it all the way down to the detail that we wanted to, but there's a lot of areas that I think won't be surprising to you, but might benefit from the conversation we just had, right? Exactly, like where do we apply the incremental or marginal resource there? So so just to say that for folks who are not aware, that we brought about 60 people together in April with HIMSS to talk about consent, and all those people were involved in consent in some way, prior work that we've done in other areas and intersecting. And it was great to be at HIMSS and have everybody together. And we were looking at really the goal of it, the last point here was to identify some actionable policy recommendations that, we have a list, but what are the one or two things that really would make a difference? Similar to looking at consent 2 years ago, is really that bubbled up to say time to really look closely at that. So we did some opportunities to share information and the like, and I don't need to go into the details of that. We did sort of focus the conversation in 5 areas: on equity and governance, technology, interagency systems and administration, and legal privacy and confidentiality. So there were 5 groups that worked together most of the day, and there were several iterations of conversations around the questions. We provided some very specific questions. Those questions were based on the Thompson family. We were talking about use cases and user stories before. This, as many of you know, the Thompsons are a family that has gotten a lot of work and is continuing to be applied and refined in different places. So the conversation was grounded in Jameson or in John or one part of the conversation, whatever the table wanted to think about. As I said, it didn't get all the way to the implementation level, but it put it in the context of a family and a person with multiple needs. And what came out, we were hoping that what that would do is that would generate sort of a standard, a sort of a system level perspective on, hey, this is not, you just can't treat this one individual because they're in a system, they're in a family. So what we have done, and again, I'm not going to go through this now, we're going to send this out, but we have a summary of the introductory comments of the 5 or 6 presenters who were part of the facilitation. And then each of the 5 work groups actually distilled down their notes into a couple of pages, narrative. And then from there, we started to bring together the recommendations that got distilled out from those, so that we can sort of pull that down, I guess. I'm not sure what the methodology is, but we've used it many times to kind of synthesize it down to what really matters. And are we finding consistent themes and requirements across? And we did, of course. So these are 5 of the sort of the key themes, obstacles to data sharing, none of this stuff is going to be surprising to you. Although a couple things that, I'll just emphasize, again, it's nobody's job. I'm glad to hear that there's some early discussions around, well, maybe it is somebody's job to do that. But the idea that that's the interstitial tissue is a big deal. There's training, trust, standards, common legal frameworks. How do we name this stuff? How do we really educate and communicate to people this really complicated stuff? And that the real important role of bringing, the customer's voice into the conversation, both for authenticity and for trust, for people to understand what it is we're asking them to do and not to be coerced into providing their consent, really hugely relevant. So there's more about each of these pieces in that distillation, but this is again, in some ways it recapitulates many of the themes we've heard yet again with a little bit more specificity. And so what I want to do is just, I want to walk through this briefly, and then as I said, I'm going to send this out to you. You want to spend a couple minutes? We're happy to go into double overtime today. So we sort of took another cut at those key issues and observations into sort of recommendation areas. So there's advocacy, there's governance, there's 6 areas. And you can read through this. Some of them are just consistently are referencing the obstacles. But I think a couple of things that really pop out at me, again, is people would live, we have to be talking to people, and we have to hear it, and we have to be able to give this information back to them in a way they can hear it and understand and trust. One of the things that really jumped out as we were sort of preparing for the event and through the event, and then hearing Stefan, Konya talk about what's coming on there, and some of the other folks that have been talking, is that from a policy perspective, we are at a juncture now in history where if we don't embed this in cures and in CDC, ONC data modernization, and in TEFCA, and in the accelerator programs explicitly, then the ship will have sailed, and we'll always be in catch-up mode. It'll be another 10 years, because everybody I've spoken to in each of these areas sort of references social care, but it's not the middle of the plate yet. It's coming, or it's on the roadmap, whatever. When we talk to them, it's like, yeah, if we should get that into the architectural plans. We should get that into the strategic plans. We should make sure that social care is part of it. That may be the most important thing that we focus our attention on, is sort of driving that conversation. And that's my bias here, is that if we want to talk about policy changes, no one's creating new policies, and going into the 3rd year of this administration, but can we affect this and the money that's going to be following this over the next couple of years? And this is, an advocacy and a lobbying. And as I mentioned before, there are people, on this call who are, our friendly feds who are showing up and participating and saying, yeah, we want to participate. And all of us, or many of us, have talked to folks, and I have as well, within HHS, within ONC, within CDC, within ACF, all of the 3-letter agencies, that don't carry guns, and then some that do, I guess, but even on the justice side. Being in that conversation, creating forums for them to come to, because it's an easier way to participate in this. And I'm hoping that ONC we heard a little bit about that ONC is going to, put out some more LEAP grants, and they're going to be sort of refocusing on this probably, again, next fiscal year. So that's advocacy. Governance, I think we've talked about this, it's got to be a job. It's got to be a named job, and it's got to be referenced that way. And it brings a lot of experience. Someone's got to bring a lot of experience to the table to do that. And it needs to be a system of systems approach. That whole area of system of systems engineering, the APL folks that, that I learned from at Hopkins and others who brought to the table, that's the solution. And that's, in my opinion, the solution to the wrong pockets problem. Because if we think about system of systems and we procure from a systems level perspective, then who's paying for it and who's getting the benefits, who's getting the credit is less relevant. And as we talked about it previously, and as I'm sure we'll talk more about the wrong pockets issue, is if we create the right incentives, so you make an investment and I get the benefit with the kids who are in foster care or the older adults or whatever, there's more collaboration, there's more fungible dollars that we can use to build common data sets and standards, which are going to be really, really, really relevant. There's another piece here about standards-based universal consent template. The work we're doing in California now under the California Healthcare Foundation. I don't know if Dan is still on the phone here, but he's one of the 3 test sites to try to do a universal consent. And one of the things we heard from talking with 25 different sites was, thank the Lord that the state is giving us something to respond to, because we want the direction. Otherwise, all the counties will create their own stuff. Some have very stringent sort of privacy officer regulations, some are less. There's almost an ask by the counties to the state to say, just tell us what to use, tell us okay, and give us safe harbor using it, and we'll do it. Give us the standards to work against. So that's a really important piece that I think we're hearing about. Really, this fed to sort of the fed to field idea of providing some consents. And there's 3 or 4 or 5, maybe even more across the country that are working. I've mentioned before Arlington County, Colorado. California's now got one. Maryland has probably got one there. We don't need to recreate that. We need to sort of do it 90% and let people customize it. On the processes and administrative stuff, a common legal framework. Again, there's just incoherency between at the state level and federal level. There's a democratization of where you come into the system. And if you come in through the ER, or if you come in through a social services safety net program, are you, is there a hierarchy to getting your needs met? Do you have money? Do you have good insurance? Do you have bad insurance? How we think about that is really going to be important. And then I think this is categorized here. And again, all this is up for discussion or commentary, but there are multiple opportunities to do POCs, and there are some that are already happening. How do we bring those together? I think that's a federal effort, or at least a national effort, to say, and that's the whole purpose of trying to do these POCs that we've been talking about out of the National Action Agenda. Let's have a library of them and understand who's doing what. If it's housing in Minnesota, and if it's early intervention in New York, and it's behavioral health in Colorado, and it's something else somewhere else. Let's bring those together. Let's learn from them. Again, hopefully using the same kind of family personas and use cases. A few more things here and there. I'll stop. But funding and financing. Medicaid says, come and get it, to the states. We'll fund consent processes 90%. Ed Dolly, I heard that directly from his mouth. Go talk to your regionals. Consent will help the Medicaid program. No ifs, ands, buts about it. Go get the money. It's a sustainability. I mean, I can say this with as much confidence as I've ever said anything, I think. No, I can say it truthfully, because this will help the Medicaid program. Consent is critical to reducing the friction. It's up to the states, and it's a de minimis amount of money to do this and to sustain it over time, in my opinion. And to be able to start with the end in mind, to say there's a funding stream that will take us through this, take you through it as a state, with maintenance and operation going forward. Anyway, funding shouldn't be an issue. And again, coming back to the, the savings and the idea of wrong pockets, how do we reinvest in that? There's all sorts of issues around culture, communication, and research, and understanding what's really working, on the promising technologies. A lot of good work going on there. Just need to bring it together. But again, it needs to be a program in a sense that can be agile, that can bring people together, bring organizations in to publish that stuff. Should it be a foundation? Maybe they're doing some good work in that area. Obviously RWJF is, California Healthcare Foundation, publishing a bunch of stuff around that. The Benefits Data Trust has done stuff out of University of Pennsylvania. There's a lot of research going on, again, synthesizing and bringing it together. Here are some of the promising practices and building that library. I think is crucially important. And then, of course, the national collaborative, like where does this all fit? And, again, consent and social care should be part, in my opinion, of, Office of the National Coordinator for Health and Human Services or Social Services. But bringing people together will be critical, continuing to bring people together to think about what are the advocacy and legislative reforms that are necessary and driving a common message. So there's different areas. I mean, I think, correct me if you have a different opinion, but all of these things are important. But what's most important? What are the three things we can do in 2023 and 24, 25 to get that started? And that's the conversation we want to have over the next couple of weeks. And I think the best way to do that might be to, share the draft report, structure this, have people really think about this a little bit, come to the table, and engage in this conversation in a more in a continuingly sort of thoughtful and articulate way. So let me pause for a second and ask for any commentary, any thoughts, amens, or questions before we move into double overtime here. And the question on the table is, y'all want to participate in that kind of refinement and to have this kind of opportunity to present it, or at least to advocate for what we want to see happen at the federal level, to develop a kind of a common voice, so to speak. Thumbs up are good.
I just wanted to comment on Dan's comment in the chat. And it's always been interesting, and a lot of times Medicaid, lives within a human services department because it's a social welfare benefit. But I always used to say we need to put back at the federal level health education and welfare. But it's interesting, just your way of saying, like, let's just wipe out the differences. And instead, what we see in states like the one I live in, New Jersey, states like Colorado, is increasing segmentation of services. So anyway, just wanted to throw that out there. Not answering your question, Daniel. Sorry.
Well, I know you're committed to it. I think there's a lot of value in having, again, multiple voices sort of suggesting where to invest energy and time and effort. So I certainly invite you all to participate in that, and we'll continue to create the forum to engage in that conversation and hone that message as best we can. All right, any last thoughts before we sign off the stalwarts on the call here? Okay, well, I suspect we'll be out in a couple of weeks with another version of this, or the next chapter on this. So thank you all for joining today, and look forward to talking to you after the 4th. Have a good 4th of July weekend, everyone. Thanks, Brian.
Sounds great.
Department of Thriving. Yeah, I like that better.
Bye, everyone.
Well, take care all.
Bye, everyone. Thank you.
Take care.